So this lecture is going to be on management of GI disorders, nutritional deficiencies, and anemia in the older population. At the end of this presentation, you guys should be able to recognize the impact of those GI disorders in the elderly, recommend treatment goals and appropriate drug therapy for those disorders, recommend treatment goals and strategies for maintaining optimum nutrition, characterize the common causes and complications of anemia and prevalence in the elderly population, and develop a treatment plan for a patient with anemia that includes pharmacologic and non-pharmacologic therapy. So as an outline, we'll talk about GI disorders, and what we won't discuss that was in your book, but you are still required to read the information, is dental hygiene and diverticulitis. So make sure that you read those sections in that chapter. But we will talk about dysphagia, GERD, constipation, fecal incontinence, and C. diff. And then we will talk about geriatric nutrition and nutrient deficiencies along with anemia. So with our GI disorders, GI symptoms typically occur throughout the lifespan. We all experience some type of GI issue, and they oftentimes cause discomfort. GI disorders are influenced by and can influence activity level and can impact quality of life. So lots of these symptoms can affect appetite, they can affect enjoyment of food, ensuring proper nutrition. And in our older population, there are different physiological changes that occur in the GI tract that can increase the incidence of dysphagia or difficulty swallowing, GERD, nausea and vomiting, constipation, diarrhea, or fecal incontinence, and malnutrition. And pharmacists do have lots of different challenges. So one of those challenges would be avoiding or minimizing medications that can exacerbate these GI issues, because we do know that there are lots of medications that can cause nausea and vomiting. There's lots of medications that can cause acid reflux or constipation. So it's very important for us as pharmacists to be able to identify whenever a patient has an issue and do a medication review to ensure that the culprit is not a medication. And if it is, figure out how to address it appropriately. The second challenge would be implementing therapy to adequately treat those symptoms without exacerbation. This can be a challenge because some of the medications for some of these GI disorders we'll be talking about, they have consequences with long-term use. And so with that, the third challenge would be continuously evaluating therapy to reduce those long-term complications. So now we'll get into the GI disorders. So with dysphagia or difficulty swallowing, this is not a normal part of aging. That's something very important to remember. Aging alone causes mild esophageal motility abnormalities, but they rarely are symptomatic. The prevalence is unknown, and it varies within settings. So it is estimated to affect 10 to 30% of the older population, but it has been shown to be increased in institutional settings like nursing homes. Difficulty swallowing is associated with longer inpatient hospital stays, a higher incidence of complications, and we will talk about those, and an increased need for services and care. And difficulty swallowing can occur due to several different factors. So assessing these individuals is very important for determining the cause and instituting appropriate treatment. But dysphagia can be classified as oropharyngeal dysphagia and esophageal dysphagia. So with our types of dysphagia, oropharyngeal dysphagia is more common. It's also known as transfer dysphagia, so there will be a difficulty initiating a swallow or coordinating the movement of food or liquid from the mouth to the upper esophagus. So they have difficulty actually swallowing. It can be accompanied by nasopharyngeal regurgitation, aspiration, and a sensation of residual food remaining in the pharynx. Again, this is the most common form. And some causes include certain neurological disorders like stroke, although swallowing issues that occur with stroke can be reversible. Other neurological disorders include Parkinson's disease and dementia. Unfortunately, with dysphagia in Parkinson's disease and dementia, the prognosis is typically less, and it might not be reversible. And then we have drug-induced swallowing difficulty. So we know lots of medications can cause issues. With our anticholinergics, swallowing function and coordination is dependent on cholinergic innervation. So those medications that affect the cholinergic receptors can cause issues swallowing. They can also cause dry mouth. With our antipsychotics, they affect dopamine, and with our antipsychotics, they block dopamine, which can cause a pseudo-Parkinsonism, which has symptoms similar to Parkinson's disease. And we know Parkinson's disease is a disorder of muscle function. So that's one of the main reasons why antipsychotics can cause issues with swallowing. And then we have barbiturates or other CNS depressants, because CNS depressants, what they do is they decrease awareness and they decrease that voluntary muscle control. And you can also include, so CNS depressants, anything with anticholinergic activity like TSA or TCAs, those muscle relaxants, any of these things can cause difficulty swallowing. With our esophageal dysphagia, this is also known as transit dysphagia. So these individuals who have esophageal dysphagia, they will be able to swallow, but after they swallow, there's a difficulty transporting the food or liquid through the esophagus. It is accompanied by a sensation of food getting stuck. So that's typically a common complaint. And some of those causes are anything that potentiates esophageal stricture or esophageal injury. So esophageal cancer, if there's been radiation therapy to that area, chronic heartburn can potentiate esophageal injury and even esophagitis. It can also be drug-induced, and typically with the drug-induced esophageal dysphagia, this typically occurs because of actually causing esophageal damage. But any medication carries the risk for esophageal injury when administered improperly. So when we talk about administering improperly, we talk about dry swallowing, meaning individuals will take medications without water or with minimal water. And then, of course, those medications that can cause esophageal injury, like our bisphosphonates, we do know that that's that recommendation where after patients take a bisphosphonate, they have to remain upright for either 30 or 60 minutes. And the main reason is because of that, it can damage the esophagus. Also, NSAIDs, we do know that they cause esophageal injury because they do increase acid in the stomach. Also, iron supplements, certain antibiotics, these things can cause harm to the esophagus. So some of those things that we would want to make sure to educate patients regarding when they're taking their medications to decrease the risk of esophageal dysphagia is to remain upright after they take their medication. And there are those specific medications that indicate how long they should remain upright for. But we do want to make sure that they avoid lying down within 30 minutes after taking any medication, just to prevent that, reduce that risk. We want to make sure they take all of their medications with enough water, at least 100 milliliters of water, and take one medication at a time. Some individuals like to take multiple medications at the same time, but taking one medication at a time will reduce the instance of the medication actually getting stuck and causing further harm. There are a lot of consequences of dysphagia. So when individuals have difficulty swallowing, there's obviously that choking risk. And this is because there's a compromised cough, gag, and swallow reflex. They can develop aspiration pneumonia. And this is typically attributed to the decreased cough reflex and age-related changes in immune response. But we'll talk about aspiration in a little bit. And then it can also increase the risk for malnutrition, because there's an obvious difficulty swallowing, so they have difficulty swallowing food, and there is a decreased palatability of food when the consistency has been altered to facilitate swallowing. So when individuals have dysphagia, one, they can experience malnutrition because they do have a difficulty of swallowing food, and one of those things to assist with that is adjusting the consistency of the food. So sometimes it might be chopped food or pureed, and a lot of times this is just not palatable for individuals, so they'll be less likely to eat. When we look at those signs and symptoms of dysphagia, obviously there's going to be swallowing difficulty. With oropharyngeal dysphagia, there can be pain or discomfort upon swallowing. There can be coughing or choking, and they have issues with both solids and liquids. So remember, OD is when an individual has difficulty initiating a swallow. So they will have issues with both solids and liquids. With esophageal dysphagia, they'll have complaints of food getting stuck, and they may have issues with solids only, but if their issue continues, if their esophageal issue continues, they could develop difficulty swallowing liquids, but typically they have issues with solids only. And then there's also some silent symptoms that we have to look out for, particularly with aspiration. So watery eyes or runny nose, congestion, they can have an increased coughing or shortness of breath after they eat or drink. And some of the associated symptoms that can occur, and this can help with differential diagnosis, includes heartburn, because heartburn can cause esophageal injury, and weight loss, hematemesis, which can indicate that there might be a GI bleed or an ulcer, which will also indicate that there is esophageal issues. Also anemia, regurgitation of food particles, and respiratory symptoms. And if individuals are experiencing any of these additional symptoms, further evaluation will be warranted because it could indicate something else, like an undiagnosed GI bleed or possibly even esophageal cancer. So when it comes to assessing patients for dysphagia, the initial symptoms of dysphagia or aspiration should prompt assessment by a specialist, particularly a speech therapist or a speech language pathologist. And anytime a clinician sees that a patient might have difficulty swallowing, they definitely should make every effort to refer them for official testing. But there's one assessment called the clinical swallow evaluation, and this is a bedside assessment. And what they do is they assess the level of consciousness of the patient, they evaluate their posture, they have them do a voluntary cough, they look at voice quality, because some individuals who have dysphagia, if they aspirate, they can have a very wet voice quality. Saliva control, they'll also look at muscle strength, movement, and coordination while swallowing. So they'll do the examination and they'll have them swallow saliva, foods, and liquids. One thing to note about the clinical swallow evaluation is that silent symptoms of aspiration cannot be detected. So that's one important thing about this assessment. The second assessment is the video fluoroscopic swallow study, or it's also known as the modified barium swallow study. And this is the diagnostic procedure using various fluids and liquids mixed with barium. And it's an X-ray type of assessment. And what it looks for aspiration, and it can also assess the amount and timing of aspiration and assess the anatomy and pathophysiology of the swallow function in the oral pharyngeal phases of swallowing. So again, this is an X-ray, and they utilize barium that is mixed with foods and liquids to see if the individual is actually aspirating. And this is a video that actually shows what the video fluoroscopic swallow study looks at. So we'll watch this video and I'll show you guys indication that this person did aspirate some liquid. So you can see in the main area where the person swallowed, you can see the majority of the fluid went in one pathway, which was down the throat. But if you continue watching, you can see right in this area, the individual actually aspirated. So that liquid went into the lungs, and they didn't cough or anything, which means that in some individuals, if they do aspirate, they might not necessarily cough and we might not know. But if they do aspirate, there is a risk for certain issues like aspiration pneumonia, and we will talk about that later. So this is a flow chart looking at whenever we assess someone who has dysphagia. And it's pretty easy to follow. But of course, you want to take that medical history to see if there's anything contributing to their difficulty swallowing. And if they have difficulty initiating a swallow associated with coughing, choking, or nasal regurgitation, then they have OD. And remember, OD is the most common form of dysphagia. If they have that sensation of food getting stuck in the esophagus after they swallow, which means they don't have issues swallowing, but they do have issues with transfer, then they have esophageal dysphagia. And so then you can assess for, is it solids and or liquids or just solids only? And then you go through and you can see if it's intermittent, then they might have primary or secondary esophageal motility disorder. If it's progressive, meaning it wasn't sudden and it took a little bit of time, then they could possibly have, if they have chronic heartburn, then they might have scleroderma, which is the thickening of the esophagus. So there's a decrease in the food passage and regurgitation. If they have regurgitation and respiratory symptoms and or weight loss, then they could have achalasia, which achalasia is narrowing, it's actually nerve damage in the esophagus. But then if they have issues with solids only, there could be a mechanical obstruction. And if it's not progressive, then they might have some esophagitis. If it is progressive, then we'll have to look at chronic heartburn, and if they have peptic stricture, which is a narrowing of the esophagus, or if they are elderly and they have significant weight loss and or anemia, there's a chance that they might actually have esophageal cancer or gastric cardia cancer, which is cancer of the upper opening of the stomach where the esophagus meets. So when we talk about managing dysphagia, it's based on the type and severity of swallowing issue identified. It's also going to be based on cognitive function because some of the therapies that are recommended, individuals do have to be cognitively aware to be able to do some of these things. So with the neuromuscular re-education, this is muscle strengthening exercises that target those specific muscles to help improve swallow function. And normally this is done after they do that fluoroscopic study. And with the neuromuscular re-education, a cognitively disabled person may not be able to do those strength exercises. So that's one of the most important things to remember. There's also compensatory strategies where they do certain precautions to help compensate for particular swallowing issues, reducing the risk for aspiration. So they might eat and drink in certain positions to decrease the choking in aspiration. There's the diet and liquid modifications where the texture and consistencies of foods will be changed to allow for safer swallowing. And that means that they might have mechanically altered food where it might be chopped really, really fine, or they might have to have like a pureed diet depending on their issues swallowing. And then at the last resort would be nutrition via enteral feeding tubes. So with dysphagia, pharmacists are very vital in determining those medications that can be altered for individuals who have difficulty swallowing, or if they have to have an enteral feeding tube or a PEG tube. So alternate formulations may be suitable, like orally disintegrating tablets, patches, liquids. But with these different formulations, a lot of times they are more expensive. So cost and accessibility should be assessed. We also have to take into account some of those age-related changes that might cause pharmacokinetic and pharmacodynamic alterations in drug metabolism. So for example, our patches, we know that our older patients do have changes in their skin. So if there's a formulation available, we'd have to make sure that it would be okay for them to have the actual patch and that they won't be put at risk for having higher drug concentrations or lower drug concentrations depending on the medication. Liquid formulations may be more expensive or not formulated correctly. And some liquids that are marketed are for children, and they might require higher volumes for the adults. So if they already have difficulty swallowing and we need a dosage that would be appropriate for an adult, they might have to consume a lot more of that liquid. We also have to take into account with liquids that there could be alcohol in these formulations. So the alcohol concentration and the dosage needed should be assessed, because if it is something where they need a high dose, and which means they would have to have a high amount of that liquid. If it's an elixir, then that means that they would be consuming a higher concentration of alcohol, and that would not be appropriate for our older patients. So as pharmacists, we must be familiar with those medications that are suitable for crushing and or administration via a feeding tube. So in general, immediate or regular release medications, if alternate formulations are not suitable, immediate or regular release medications can be crushed, or the capsules can be opened. And this is going to be one of the preferred options, just because remember, our alternate formulations might be a little more expensive. Now, if the patient can afford those alternate formulations, then that would be perfect. But if not, then immediate and regular release medications can be crushed, and the capsules can be opened if needed. With our extended release, control release, long-acting XRs, or enteric-coated tablets, these things should not be crushed. But there are some extended release or control release capsules that can be opened and sprinkled on a small bit of applesauce, but they should not chew it, because typically when our capsules, if they're extended release capsules, they typically have small beads on the inside that are extended release. And then there are certain extended release or control release tablets that might actually be dispersible if put in water. So they can be put in water and dissolved. Some of our potassium supplements they're dispersible tablets, so they can actually be put in a little bit of liquid and they'll actually dissolve, and they can be taken like that. But proper administration with the medications that are crushed, we would want them to mix it in a small amount of jelly or similar substance, maybe a little bit of pudding. But it's very important to note not to put the entire portion, not to put it in an entire portion of food or drink at meal times. So the medication should be put in a small amount of jelly or pudding, because if we put it in an entire portion of food or drink, there is a chance that they might not eat all of that food or beverage, and meaning they will not get the full dosing of the medication. So another complication of dysphagia is aspiration pneumonia, and this occurs due to microorganisms that come from the oral cavity or the nasopharynx, because of a compromise in the usual defenses that protect the lower airways. So in our older patients, there's that decreased ability to forcefully cough. There can be a reduced gag reflex or difficulty swallowing, and an inability to clear particulate matter that has reached the lungs. So in older patients, they might not, their cilia might not be working as properly. So if something gets in the lung, they might not be able to cough it up to clear it out. And then there's also those changes in immune response, and all these things can contribute to the development of aspiration pneumonia. It's typically polymicrobial, but there are other factors that we do have to take into account for appropriate antibiotic selection. So we have to take into account functional status of the individual. Is there a presence of underlying respiratory conditions, or do they have an enteral feeding tube? Because these additional patient factors might warrant more aggressive treatments, because they might be more likely to experience pneumonia due to other bacteria outside of the anaerobes or streptococcus, like Pseudomonas or other drug-resistant bacteria. So now we'll get into gastroesophageal reflux disease, or GERD, and it is one of the most prevalent GI disorders. And if you guys remember from patient counseling last semester, We talked about acid reflux and how would we know if someone has GERD versus just infrequent reflux. So acid reflux typically is acute and infrequent, and it's normally worse in the evening. And some individuals might experience symptoms immediately upon waking or with exercise. So they might experience some acid reflux with activity. Those who have reflux that's frequent and persistent, meaning greater than 2 times per week for 3 or more months, they most likely have GERD, and they definitely need to be treated. Symptoms include heartburn, that food regurgitation, so they will have the regurgitation of stomach contents into the esophagus. Some additional symptoms can be cough, hoarseness, or laryngitis. They could experience postnasal drip, worsening of asthma, and even non-cardiac chest pain. The prevalence of GERD increases with age due to certain physiological changes. So there is that slowed gastric emptying, and there is a decrease in saliva production. There's also reduced intra-abdominal length of the lower esophageal sphincter and an increased incidence of hiatal hernia. And a hiatal hernia can it's sort of like a bend in the upper stomach, and it causes stomach contents to be pushed up into the esophagus, causing GERD or acid reflux. Older individuals can be asymptomatic or present with atypical symptoms, and some of these atypical symptoms can be alarming in older individuals. So they might experience dysphagia or difficulty swallowing. They could have cough, wheezing, or chest pain. And when our older individuals experience some of these symptoms, it is typically a cause for alarm because they might think that they're having a heart attack when really they're just having indigestion. But there are lots of different complications of GERD if it goes untreated. So they can experience esophagitis, gastrointestinal bleeding, which is very serious, Barrett's esophagus. It can even cause esophageal cancer, anorexia and weight loss, and even anemia. So for your first lecture question evaluation, I want you guys to review Ms. Penny's profile and identify those risk factors that she has for GERD. And then what non-pharmacological treatments can be recommended and what pharmacological treatments can be recommended. And what counseling points should she receive? And then I also want you to identify monitoring parameters that should be given since she is older. So when you recommend a pharmacological treatment, I want you to identify those monitoring parameters that should be done given her age. So with risk factors, we do know that lifestyle plays an important role. So our diet, some of the foods that we eat, eating certain acidic foods like orange juice, tomato-based foods, fried foods, even meal size can be a risk factor for GERD because eating large meals can cause some of the stomach contents to be pushed up into the esophagus when the stomach is very full. Also, reclining or laying down after meals. Having a heavy weight can increase the risk for GERD, tobacco use, stress, wearing tight or restrictive clothing. And of course, medications can increase the risk for GERD. Remember, we just talked about drug-induced esophageal injury. So those medications that can cause esophageal injury, they can increase the risk for GERD. So our NSAIDs, like our Motrin, Aleve, iron supplements can increase the risk for GERD, bisphosphonates, anticholinergic medications or medications that have that anticholinergic action, calcium channel blockers, cholinesterase inhibitors, and even certain antibiotics. So all of these medications have the potential to cause esophageal injury. And if not caught in time, it can be a risk factor for developing gastroesophageal reflux disease. So when we talk about treatment, our standard treatment is going to be based on the frequency and the severity and the onset and duration of symptom relief provided by those medications. So in all of our patients, we do want to recommend lifestyle modifications. So you guys should remember from last semester some of those lifestyle modifications that we would counsel patients to do if they do experience or have GERD. Then we also have those pharmacotherapy treatment options. So for intermittent symptoms or infrequent symptoms, antacids can be used. And then we also do step up or step down therapy in our older patients with our H2 receptor antagonists and our PPIs. But special consideration should be taken in terms of symptom management because we have to think about duration of therapy and complication with long-term therapy, and of course the anticipated side effects and potential drug interactions with these medications. So with our first class of medications are antacids. Again, it's used for intermittent symptoms, and these do not provide acid suppression. And acid suppression is the standard treatment for GERD, but antacids can be used if individuals need immediate relief. But some considerations that we have to take in our older patients would be those with renal impairment should not use aluminum or magnesium containing antacids unless directed by their physician because it can cause issues with their renal function. They are more susceptible to side effects with overuse. So when we look at some of those dose-dependent side effects, diarrhea, especially with our magnesium-containing antacids and our combination of aluminum and magnesium-containing antacids. They can also experience dose-dependent constipation with aluminum or calcium-containing antacids. So it's very important to make sure that if they're utilizing antacids to let them know that there are certain side effects that can occur, especially with higher doses. Interactions can occur with certain medications. You remember our antacids, because they contain some of those cations like calcium, magnesium, aluminum. They do have drug interactions with certain medications, and it does require spacing. The antacids, they work within minutes, and it can provide relief from mild and frequent reflux. But unfortunately, the relief is only temporary with antacids, typically about 30 minutes on an empty stomach. And another thing to note that some of the antacids contain bismuth subsalicylate or salicylates, which is also another word for aspirin, and it can turn the tongue and stools black. The bismuth can. And then it can also increase bleeding risk when taken continuously or with other medications that increase bleeding risk. So that would be very important, something that we definitely want to be mindful of with our older populations. And so this is a chart of some of those common antacids and the brand names. I think it is similar to what you guys received last semester in patient counseling, but you can see we have many different brands and formulations available for individuals to choose for their treatment of reflux. Our second class of medications is going to be our H2 receptor antagonists, and these are going to be used for step-up therapy for mild symptoms. So what this means is they will begin on an H2 antagonist, and then they will step up to a PPI. And some of our H2 antagonists that we have on the market are cimetidine, famotidine, and nizatidine. But with these medications, they are on the Beers criteria. We do have to be careful with them because older patients are going to be more sensitive to the CNS effects. So they can potentiate cognitive impairment, and they can induce or worsen delirium, especially in those patients who are renally compromised. They can also cause QT prolongation, specifically in those who are renally compromised as well. Cimetidine should be avoided due to those extensive drug interactions, and many of our older patients will be taking many medications. So cimetidine should possibly be avoided if at all cost. But again, these medications are on the Beers criteria, and our older patients will be more sensitive to those CNS side effects. But they do work within 30 to 45 minutes, and they can last up to 10 hours. They can be taken with an antacid if immediate relief is needed for their heartburn. Twice daily regimens will be needed for daytime and nighttime symptom relief. But of course, we do have specific timing for doses. If they have nighttime symptoms, early evening around 6 p.m. dosing is recommended. Specifically 30 to 60 minutes before dinner, and this has been shown to provide better symptom control than bedtime dosing. And our last medication class for GERD would be our proton pump inhibitors. So our PPIs are used for step-down therapy for severe symptoms and if individuals have ulcers because of their GERD. So what will happen is they'll begin a PPI and they'll continue it for 6 weeks, and then they will step down to an H2 receptor antagonist. Pending symptom resolution. So if they're on a PPI for 6 weeks and then they begin, they step down and start taking in H2RA, but their symptoms come back or they don't improve, then they will more than likely have to be on a PPI. PPI therapy may be warranted for those who are over 60 years of age with symptomatic GERD and or chronic NSAID use. So it's very important to keep this in mind. So long-term use is definitely warranted with specific patients when they're older. And those are the ones who, if they have symptomatic GERD and or they're utilizing chronic NSAIDs, they have been shown to be much more efficacious as compared to the H2 receptor antagonists, and they have that once-a-day dosing. They do have minimal CNS side effects, but with our PPIs, routine evaluation should be done to ensure appropriateness of long-term therapy, meaning if the patient does not have symptomatic GERD or if they're not on chronic NSAIDs, we have to evaluate if this is going to be appropriate. And for this reason is our PPIs are also on the Beers criteria. So they're on the Beers criteria for the increased risk of C. diff infections and fractures. So the Beers criteria recommends that use of a PPI not exceed 8 weeks unless there is a high risk. And those high risk patients would be those individuals who have GERD, if they have esophagitis, or if they have chronic NSAID use. So again, if we have a patient who is older and they don't have GERD, they don't have esophagitis, they're not taking NSAIDs chronically, then we would have to evaluate if a PPI is appropriate for them to be on for long term. Special care should also be taken in those receiving clopidogrel because our PPIs can reduce the metabolism to the active form, so it can reduce the efficacy of Plavix. There's some data out there that indicates pantoprazole is the preferred PPI if a patient is taking Plavix. And I just mentioned the considerations with our geriatric patients, so we want to avoid use greater than 8 weeks unless it's appropriate. So remember, it can reduce the calcium absorption and increase the risk for osteoporosis-related fractures. And then they do alter that gut flora and increases the risk for C. diff. So again, those individuals, we want to make sure that long-term PPI use is appropriate with those previous things that I mentioned they had to have. With the PPIs, they do take a little bit of time to work. Onset is 2 to 3 hours, and they can last up to 24 hours. If they're experiencing nighttime symptoms, evening dosing is suggested, preferably 30 to 60 minutes before a meal. And our formulations that are extended release, that come in extended release capsule formulations, omeprazole, esomeprazole, lansoprazole, and dexlansoprazole, these things can be sprinkled on food and taken immediately, but of course we don't want to chew them. So this would be a good a benefit for an individual if they do have difficulty swallowing, that those things can be opened and sprinkled on applesauce. So now we will talk about constipation. Constipation occurs in about 16 to 20% of those who are older than 65, and then the prevalence actually increases as they get older. And it has been shown that 50 to 79% of nursing home residents actually complain of constipation and or take a daily laxative. And with these statistics, the prevalence varies due to the definition of what constipation is and the belief of how many bowel movements is considered normal. So historically, constipation was defined as less than 3 bowel movements per week, but infrequency doesn't necessarily correlate with pathophysiology or symptoms. So now they're saying that constipation is if they have 2 or more of the following symptoms for 3 months with a symptom onset greater than 6 months prior. So if they're having straining during 29 or 25% of the time when they go to use the bathroom, if they have lumpy or hard stools 25% or more times, if there's a sensation of incomplete evacuation, so they go to use the bathroom and they still feel like they haven't finished using the bathroom and they can't, a sensation of anorectal obstruction or blockage 25% or more of the time, manual maneuvers to facilitate defecation 25% more of the time, and less than 3 defecations per week. So typically all of these things would encompass an individual having chronic constipation. But there are some symptoms that if individuals have these symptoms in addition to their constipation, they do need to have further evaluation. So if they have hematochezia or blood in the stool, this might indicate, and typically hematochezia is red blood. It can indicate that there might be a lower GI bleed. If they have melena or dark blood in the stool, this could indicate an upper GI bleed. If there is a family history of colon cancer or inflammatory bowel disease, that they might have potentially those issues. If they're experiencing anemia or weight loss or nausea or vomiting. And all of these symptoms, they're typically uncommon with constipation, but if an individual does experience them, we do want them to get further evaluation. So with constipation, there are 2 types. There is primary constipation, which is considered disordered defecation, and this is the most common in our older adults. And what happens in primary constipation, the disordered defecation, there is the relaxation of the pelvic floor and the sphincters are not coordinated enough for them to be able to go use the bathroom. And then there's also slow transit constipation, which is also a primary constipation. But with this one, there's a decreased motility in the large intestine due to abnormalities with the nerves in the large intestine. And then we have our secondary constipation, which is going to be caused by something that we can typically identify. So, of course, lifestyle factors, meaning they probably don't have a high diet in fiber, they probably don't consume a lot of water or get physical activity, or medical conditions, so neurologic disorders like Parkinson's disease, stroke, they might have diabetic gastroparesis. Some psychiatric disorders can contribute to developing constipation, even some endocrine disorders like hypothyroidism, if they have any GI disorders like irritable bowel syndrome. And of course, medications can contribute to developing constipation, like our opiates, our narcotic pain relievers, antihistamines, anticholinergics, calcium channel blockers, and then some of our vitamin supplements. So we talked about calcium earlier in terms of how it can cause constipation, and of course aluminum and iron as well. So there's a lot of different things that can cause secondary constipation. So when it comes to treating constipation, it's very important that we do proper assessment so that we can identify the underlying cause of the constipation and manage and treat that underlying issue. Lifestyle modifications should be instituted for prevention and treatment of constipation. And then we do have pharmacotherapy. So fiber supplements are our bulk forming laxatives, stool softeners, our osmotic and stimulant laxatives, and enemas. And if constipation gets so severe, it can cause fecal impaction. And treatment of fecal impaction would include manual removal of the stool or enemas. And again, with treatment, special consideration should be taken with symptom management, how long they're going to be on therapy, if there's any complications with long-term therapy, and what side effects and or drug interactions the individual can experience. So with our fiber supplements, our bulk forming laxative, so if you guys remember from patient counseling, they retain water to stimulate peristalsis. And it can be instituted daily for fiber supplementation. And we do have lots of products on the market like Metamucil, Fibercon. It can affect the absorption of medication. So we want to make sure that our fiber supplements are spaced at least 3 hours away from other medications. And some special considerations in our older patients is the fiber supplements should not be used if fecal impaction is suspected, because it can worsen that impaction. It has not been shown to be effective in bedridden individuals, so individuals who are bedbound. Fiber supplements have not been shown to be beneficial for constipation. And the tablet and capsule forms of fiber should not be used in patients who have dysphagia, because if they have difficulty swallowing, what happens is the fiber tablet or capsule can actually swell in their throat and cause choking. So that's one of the reasons why they must be taken with a full glass of water, because they can swell and cause choking. The powder should be mixed with adequate water so that it can go down to where it needs to go and not get stuck in the throat. With our stool softeners, what these do is they pull water into the stool, softening for the ease of passage. And we have our DocuSate products like Colace and DocuSol, which is a stool softener enema. And we want to advise patients not to use it within 2 hours of taking other medications. They typically work within 1 to 2 days, but in some individuals it can take a little bit longer. It can take 3 to 5 days. With our considerations in our older patients, they do have minimal drug interactions and side effects, so that's definitely something really good, an advantage in our older population. But it has been shown to be more effective when individuals are doing lifestyle modification. So if they're going to be using a stool softener, of course we want to make sure they're doing the lifestyle modifications to help with constipation as well. But these also have not been shown to be effective in those bedbound individuals. With our osmotic laxatives, these draw water into the intestines to promote a bowel movement. And it's recommended if immediate relief is needed, meaning if they have if they've not had a bowel movement within 3 to 4 days. And we have our magnesium containing products, which are magnesium citrate, Phillips milk of magnesia. And then we also have polyethylene glycol or Miralax. But there are some considerations that we have to take into account for the older population. For those magnesium containing products, we do want to make sure they consume adequate water, at least 8 ounces, because again, they pull water into the intestines. So if they're not hydrated, or if they don't consume a lot of water, it'll typically be ineffective for them. But it can cause electrolyte abnormalities, and we don't want to use these in patients who have any renal issues or renal dysfunction. With our polyethylene glycol, for those who have difficulty swallowing, it is a powder that can be mixed with water or juice, but there might be a loss of viscosity when mixed into starch thickened liquids. So an alternative thickening agent should be used. So in individuals who have difficulty swallowing, if they have a risk for aspirating liquids, typically what happens is they'll mix a thickening agent into the liquid to make it a little more thick, so that it's not like very watery for them to swallow. But with Miralax, the viscosity will be decreased if they have to have a thickened liquid. So what that means is if they're mixing the Miralax with their juice that has also been thickened with a starch, there could be a loss of that viscosity. So an alternative thickening agent would have to be used. It should be dissolved in 4 to 8 ounces of liquid, so water, juice, or tea can be used. And patients should be advised that symptomatic improvement may not be seen for several days, typically 1 to 4 days. Some individuals will have relief within 6 to 12 hours, but it just depends on the person. With our magnesium citrate, those typically work a little bit faster than Miralax. And then we have our stimulant laxatives. So these stimulate rapid peristalsis to evacuate the bowels. And these are also recommended if immediate relief is needed, meaning they've not had a bowel movement within 3 to 4 days. And we have our bisacodyl and our senosides. And with these, they can cause a lot of abdominal discomfort and electrolyte abnormalities, especially if an individual is not drinking enough fluids. So it can cause dehydration and, of course, watery stools. But with our older patients, frequent use can lead to dependence or habituation. So use should not be longer than 7 days, and unintentional laxative abuse can occur and should be addressed. So a lot of times in our older individuals, they might have started with constipation and they began taking a stimulant laxative. And then what happened is they would take it continuously every day. And then they found that they were not having a bowel movement after they took the stimulant laxative because essentially their bowels were actually empty. And so they would continue to take them. And so if this is occurring in an older individual, we should definitely make sure that we decrease the stimulant laxative, make sure that we're adding fiber to their diet. And then if they need to have a stimulant laxative for occasional constipation, it can be utilized. But if they're used for long term, what can happen is they essentially lose their efficacy. But with those individuals who take opiates, or if they have constipation due to neurologic disorders, regular use of stimulant laxatives is going to be warranted to make sure that they do not experience fecal impaction. So now we'll talk about fecal incontinence, and this is the involuntary loss of liquid or solid stool, and it affects about 36% of community dwelling individuals and 33 to 65% of those living in long-term care facilities like nursing homes. And this is the second common reason for institutionalization. So typically when an older individual when they start developing issues with maintaining their bowels, this can get them to be where they are admitted into a long-term care facility because urinary incontinence and fecal incontinence has a very high risk for caregiver burden. But there are barriers to treatment, so they might be embarrassed or they might identify it just as diarrhea, and it can significantly impact quality of life. With fecal incontinence, it's very important, no matter what the cause is, that individuals be assessed for skin breakdown, because what can happen is if someone is experiencing fecal incontinence, if they're not having the proper hygiene, if they're bedridden, they can develop pressure sores and infections. So it's very important to make sure that we're assessing to ensure that they're not having skin breakdown or experiencing any type of sores or anything that can increase their risk for infections. But fecal incontinence can be caused by fecal impaction, diarrhea and urgency, and neuromuscular dysfunction. And treating fecal incontinence will be determined by the precipitating cause, which we will talk about. So with fecal incontinence due to impaction, now, this occurs because of the inhibition of the anal sphincter tone and laxative use. So what happens is an individual might think that they have constipation, but they have impaction. So they might think that they have constipation and they'll take a laxative. And what will happen is the treatment of the impaction with the laxative causes seepage of stool around the actual blockage, resulting in fecal incontinence. And this this is caused by 42% of cases. So treatment would include manual stool removal and enemas. And then once the impaction has been cleared, we want to make sure that we're instituting prevention of constipation. So lifestyle modification, avoiding constipating medications if possible, increasing mobility of the individual. And if laxatives need to be used, it can be routine as needed. So with fecal incontinence due to diarrhea and urgency, this is typically due to diarrheas from infection, colitis, if they have irritable bowel syndrome, if they're going through radiation for cancer, and if they're taking certain medications. So we know that there are lots of medications that can cause diarrhea. Make sure that you refer to table 11.1 in chapter 11 so that you know the specifically listed medications. For treatment, it's important to treat the underlying cause of diarrhea because this normally will fix the incontinence. When needed, fiber supplements and medications can be instituted. So our loperamide is the preferred agent due to minimal adverse drug reactions of the remaining agents that we will talk about. But with loperamide, we do have to be careful because it can cause constipation. So if individuals have diarrhea and they're taking loperamide, if they take too many or they take it too fast between doses, what can happen is they can experience constipation. And our other two agents are Lomotil and codeine, and these two are not preferred due to the CNS adverse drug reactions like sedation and confusion. So with our fecal incontinence due to neuromuscular dysfunction, this typically occurs because of neuropathy, if they've had a previous surgery, or if they have had any injuries. And treatment will involve increasing the stool bulk with insoluble fiber, instituting some behavioral strategies like toileting after meals, and even behavioral therapy and biofeedback can be done, but this is only if the individual is cognitively able. So if it's someone who has dementia, they might not be able to participate in the behavioral therapy and biofeedback. And if these measures are unsuccessful, some individuals might benefit from injection procedures where they inject collagen or silicone around the internal anal sphincter so that there's no leakage that occurs. Surgery to repair the trauma, so if they have any injury that is causing their incontinence, or a colostomy as a last resort. So for your lecture question evaluation 4 and 6, I want you guys to review Ms. Penny's profile, identify those risk factors that she has for constipation, and what non-pharmacological treatment can be recommended, and what pharmacological treatment can be recommended. And with her pharmacological treatment, what are the counseling points that she should receive, and what monitoring parameters should be done given her age. So now we'll talk about Clostridium difficile infection, or C. diff. C. diff is a gram-positive anaerobe that secretes toxins and causes severe diarrhea and colitis. And it occurs due to an alteration in the normal gut flora. So what happens is the anaerobe produces spores that can survive the acidity in the stomach and travel to the large intestines, where it causes colitis and diarrhea. C. diff can be transmitted by contact. So hand washing and hygiene practices is very important if an individual has C. diff. So that's definitely very important. So it is associated with 30% of antibiotic-associated diarrhea, and normally it can occur 2 to 3 days after exposure to the antibiotic. So it's normally going to be broad spectrum antibiotics. And it results from, I've already mentioned, the reduction in the normal gut flora causing the overgrowth of C. diff. And it has those spores, and the spores is what impairs the effort to eradicate the organism, because the spores can live through the stomach acid, and then once it gets into the lower intestine and into the colon, that's where it thrives the most. And again, it's caused by broad spectrum antibiotics like ampicillin, amoxicillin, cephalosporins, some of our fluoroquinolones. Treatment would include oral vancomycin or fidaxomicin. Fidaxomicin has a lower rate of recurrence, and oral metronidazole can be given as well. This used to be our first-line therapy, but now we have transitioned into utilizing the vancomycin and fidaxomicin as first-line therapy. But metronidazole can be used if the above agents are not available. And with our older patients, we typically need to use lower doses, especially if they have hepatic impairment. And if they cannot utilize the oral metronidazole, IV can be instituted. And without treatment, C. diff can be fatal. So now we'll talk about nutrition in our older adults. We'll talk about undernutrition and overnutrition. So with nutrition, healthy food choices positively influences the quality of life of older adults. We know that proper nutrition has health benefits, but poor nutrition can lead to an increase in dependence, poor immune function, um, increased and longer hospital stays, and it can impact the quality of life. So um, the nutritional needs of older adults are determined by multiple factors, and we did talk about these factors several weeks ago when we talked about a nutritional assessment. But nutritional needs are determined by specific health problems and related organ system compromise. So depending on what type of disorders or conditions they have. It's also determined by their level of physical activity, energy expenditure, and caloric requirements. So our older population may need less calories to maintain their current weight due to decreased physical activity. But they should consume adequate protein to prevent loss of muscle mass. And they normally need the same or more micronutrients to prevent deficiencies. So some of those include calcium, vitamin D, iron, vitamin B12, zinc, magnesium, and we'll talk about nutrient deficiencies in a little bit. It can also be determined by the ability to access, prepare, ingest, and digest food. So again, nutrition, if they're unable to access food, then that could cause them to have poor nutrition or undernutrition. If they can't prepare the food, that can be an issue. If they have difficulty ingesting it, like if they have dysphagia, or if they have digestive issues, that can impact their nutritional status. Personal food preferences can also impact their nutritional status. And nutritionists and dietitians should be involved when assessing an older patient's nutritional status. So remember, being part of that multidisciplinary team and involving those who have the specialization in certain areas. And information from labs is very important in detecting nutrient deficiencies. And again, we will talk about nutrient deficiencies later on. So with our nutrition, the current nutritional guidelines are going to be similar to those for adults. And needs are going to be, again, they're going to be very specific for their caloric expenditures and lifestyle. So depending on how much they burn. The caloric needs can be calculated by the estimated energy requirement, or the EER. And this can be done with the following equation. So it would be 354.1 minus 6.91 times age plus the physical activity coefficient, or PAC, times 9.36 times weight in kilograms plus 726 times height in meters. So I know that's a lot, but this is the way to calculate the EER for our older individuals. And the physical activity coefficient is determined as follows. So this essentially is the number that we would utilize depending on their activity level. So if individuals are sedentary and they don't do any type of physical activity, their PAC would be 1. If they have low activity, their PAC would be 1.12. And an example of low activity would be 30 minutes of leisurely walking or slow walking, if they do light housework like washing the dishes or standing. They would be considered active if they do 30 to 60 minutes of brisk walking, if they do moderate housework like cleaning windows, mopping, or gardening. And they would be considered very active if they do 30 to 60 minutes of jogging or hiking or any type of intense physical activity. So to prevent malnutrition and nutrient deficiencies, older adults should consume adequate protein. So again, our older individuals, typically as we age, we start to lose muscle mass, but we gain fat mass. So in order to help with this, the potential for losing muscle mass, we want to make sure that they consume enough protein. And the calculation for protein would be 0.8 grams per kilogram of body weight per day. So that's how we would be able to calculate how much protein is going to be needed in a day. They should also have adequate fiber intake because this can prevent constipation. And if you don't remember the fiber intake, the recommended fiber intake from last semester, make sure you review that because you do need to know what is the adequate fiber intake for a man and a woman. They should also consume adequate dairy because this is needed for calcium. And we know that older individuals are at risk for developing osteoporosis, especially our older women. So we do want to make sure that they are getting enough calcium. Having foods that are fortified with certain vitamins. And then if they need to, they can supplement with vitamins and nutrients. And I do have an updated table in this lecture that I want you guys to remember. And some of those nutrients include calcium and vitamin D, vitamin B12, and iron. So before we discuss those nutritional syndromes, it's important to know the ranges for BMI because these are used to classify the specific nutritional syndromes, i.e. undernutrition and overnutrition, or yes, undernutrition and overnutrition. So we know that an individual who is considered underweight would have a BMI of less than 18.5. If they're normal, they'll be 18.5, between 18.5 and 24.9. If they're overweight, their BMI would be 25 to 29.9. And if they're obese, they will have 30 or more, and extreme obesity is classified as 40 or more in terms of the BMI. So for your next lecture question evaluation, I want you guys to calculate Miss Penny's estimated energy requirement and her protein requirement. And she does weigh the same, and her height is the same as she's been all semester. So with undernutrition, this occurs in 14 to 27% of those individuals living out in the community, and between 25 and 85% of those who reside in long-term care facilities. So maintaining a healthy weight and preventing malnutrition can prevent frailty, and it has been shown that a low body weight has a worse prognosis than being overweight or obese in the elderly population. Further evaluation is recommended if the body weight is below 80% of the recommended weight, which they do have a recommended weight for older patients. There's a chart that indicates how tall they are, and how old they are, and it'll indicate what their weight range should be. So if their body weight is below 80% of the recommended weight, or if the BMI is less than 18.5, further evaluation should be recommended because we want to see why are they not at the specific weights. And some causes for undernutrition include inadequate dietary intake, cachexia, and sarcopenia. When we look at those causes, inadequate dietary intake, when we talked about the nutritional assessment a few weeks ago, we said there's many different factors that can contribute to inadequate dietary intake, and that includes those social factors like isolation. So a third of individuals over 65 and a half of individuals who are over 85, they typically live alone, and this can decrease the enjoyment of food and caloric intake. It has been shown that older individuals who eat with others are more likely to consume more than those who eat by themselves. So isolation could be a factor for inadequate dietary intake. We also have to look at finances because, again, our older individuals are going to be on a limited income, so they may spend money on other necessities before they spend on food. So that's something that we need to take into consideration when dealing with someone who might have inadequate dietary intake. There's also those medical factors. So they might have certain medical illnesses like cancer, depression, Alzheimer's disease. They might have difficulty swallowing, which causes them not to eat as much. They could have GI disorders like GERD, IBS, or constipation or diarrhea that causes them not to want to consume a lot of food. There are certain medications like SSRIs or digoxin. These things can cause anorexia. They can cause nausea. So those can contribute to someone not wanting to eat. And then, of course, we have those physiological factors associated with increasing in age, like the changes in taste and smell and that delayed gastric emptying, which gives them that feeling of being full for a lot longer than usual. And then there's also cachexia. And cachexia is a metabolic syndrome that is characterized by severe loss of muscle and fat, and it is associated with inflammatory and cytokine-mediated medical illnesses. So some of those examples would be cancer, AIDS, end-stage renal failure, heart failure. And with cachexia, nutritional supplementation alone cannot address it. So that's very important. And we'll talk about treatment in a little bit. But then another cause for malnutrition would be sarcopenia, which is a syndrome characterized by a loss of muscle mass, strength, and performance due to a decrease in hormone production, decreased physical activity, and inadequate protein intake. And sarcopenia is not necessarily associated with an underlying illness. And with sarcopenia, they think that it could be due to a decrease in testosterone. So and I think this might be one of the things with age. As we get older, some of our hormones are decreased. We do have decreased physical activity, and we'll typically have a less dietary intake, which could impact protein intake. So individuals who have a loss of muscle mass, strength, and performance, but they don't have any underlying medical illness that's causing it, they're more than likely to have sarcopenia. And most individuals with cachexia are sarcopenic, but most sarcopenic individuals are not considered cachectic. So remember, cachexia is that complex metabolic syndrome that occurs with certain inflammatory diseases. So how do we assess if an individual is experiencing malnutrition? So we want to make sure that we're getting a height and weight. So this should be monitored routinely, and typically this will be done with a physical exam. And of course, we want a nutritionist or a dietitian to assist with nutritional assessment. So of course, as a clinician, if you see an individual who might possibly be experiencing malnutrition, referral would be needed. But we do want to assess their height and weight. Their appetite and dietary intake should be assessed. So some of the questions about these things can be used to assess a change from their normal habits. So what is their usual appetite like, and has it changed? How is their dietary intake in relation to their usual pattern? What are the number of meals consumed per day? What are the portion sizes? If they're having snacks between meals, if and when they feel full during their meal. So how soon after eating do they start feeling full? We would also want to ask whether the patient likes what he or she is eating, because that can determine if someone decides not to eat something. When we talk about nutritional assessment, there are underlying causes of inadequate dietary intake, and there's an acronym that lists those areas that should be assessed with those individuals who are malnourished. So we want to determine the underlying cause. So if there's any disease state that could be causing their decrease in appetite, are they eating poorly? So are they just not eating enough? Do they have any tooth loss or mouth pain? So that would be where the oral assessment would come into play. Do they have proper fitting dentures? Are they experiencing any economic hardship, or are finances causing them not to be able to access food? Is there reduced social contact? Remember, so isolation can impact an individual not having adequate dietary intake. Are there medications that are causing them to be nauseous, anorexic? Is there any involuntary weight loss or weight gain? Do they need assistance with self-care? So if they have issues with the ADLs and they're not able to feed themselves, do they need assistance with feeding themselves? And are they elderly? So are they with the old where they're above the age of 80? Because when we start talking about the very old individuals, a lot of times they will have low dietary intake. And then we can also use there are different types of nutritional assessments. This was just one of the ones that was mentioned in your text, but the mini nutritional assessment, or the MNA, it is used to identify individuals who are 65 years or older who are malnourished or at risk for malnourishment. And it contains 6 questions. that asks about food intake, recent weight loss, mobility, if there's any psychological stress or acute disease, if there's a presence of dementia or depression, what the BMI is, and if an individual is in a wheelchair or if they're bedridden and they can't provide a BMI, then a calf circumference can be used. And a 12 to 14 equals normal nutritional status, and 8 to 11 indicates at risk for malnutrition, and a 0 to 7 equals malnutrition. And one of the advantages of the M&A is there is no lab data that's needed, but a full assessment and physical exam should be done in those who are either malnourished or who are at risk for malnourishment. And so that's very important because it is a very short assessment, but we do want to make sure that if there's anybody in the risk of malnutrition category or malnutrition category, then we do want to make sure that we do a full physical and exam to identify, to prevent any further issues. Your lecture question evaluation number 8. Miss Penny's primary care physician partially completed a mini nutritional assessment for her. I want you guys to finish the assessment and calculate her score and indicate what her score means and what would your recommendation be. And her MNA is posted on with her other documents on Blackboard. So now we'll talk about the treatment of undernutrition. So if there's no underlying disease that is found, then of course we would want to do that assessment and treat them for inadequate food intake or sarcopenia. So if an individual is living independently and they need assistance with those IADLs like shopping, then we would want to make sure that we institute that assistance with shopping. If they have issues with their ADLs like feeding and they need to be assisted, then we want to make sure that we're recommending them to get assistance with that. This is why a functional assessment is very important with our older individuals, because if they're not receiving the proper nutrition because they can't grocery shop or they can't feed themselves, then it's very important to make sure we do proper assessment to ensure that they are being adequately treated. Then we can lift those dietary restrictions. So if a patient is on a low cholesterol or low sodium diet, we want to go ahead and take off that sodium and cholesterol restriction, because there could be a chance that they're not eating because the food doesn't taste good. And those individuals who have diabetes, we would want to limit only concentrated sweets and monitor glucose. So if they have diabetes, then we can lift that dietary restriction of limiting sweet foods, but we would only limit concentrated sweets. So those things like candy that is very concentrated with sugar. And we can monitor their glucose, and their diabetes medications can be adjusted as needed. We also want to assure that meals and foods meet the individual taste. So consider the food preferences and the culture. I know that in certain institutions like long-term care facilities, they might have a set meal schedule or set type of food that they have. For those clinicians who are in those facilities, if there is a person who is experiencing undernutrition, possibly seeing what types of food they actually eat. And if they're from a different culture, seeing about pulling in or going to restaurants to pick them up something that they will actually eat. Supplement meals with additional nutrients, so adding protein powder to meals, adding additional good fats to sauces, doing different things to increase calorie content can be good. We can also increase nutrient-dense snacks in between meals, so peanut butter and jelly, boiled eggs, yogurt, different foods that have a high caloric content, but they also have nutrients. And offer nutritional shakes between meals. This can also be helpful in those who are undernourished. With cachexia, because of the presence of underlying inflammation and catabolism, it's often resistant to nutritional intervention. So because the causes of cachexia are multifactorial, treatment should be multimodal, meaning that we would want to stimulate the appetite, because typically individuals who have cachexia, they will have anorexia, and stimulate the appetite. We would want to provide them with things that can increase muscle protein synthesis and reduce those inflammatory processes of those diseases that they have. So with our appetite stimulants, these will be reserved as last resort, or in those who have cachexia. And with our appetite stimulants, and there's not enough data regarding the appropriate use, but it can be considered when other measures are unsuccessful. So we do have a few things that are considered appetite stimulants. We have Megace, which it has been shown to provide modest efficacy with cachexia associated with cancer and AIDS in younger patients, but there's a lot of risks with this one. It can cause thromboembolism, adrenal suppression, so there's a lot of cardiovascular risk with Megace, and it's actually not recommended by the Beers criteria. There's also Marinol, which is indicated for AIDS-related anorexia and weight loss. And with this one, there can be some CNS adverse drug reactions like cognitive impairment, hallucinations, or seizures. And mirtazapine, which we know is an antidepressant, this one is beneficial in weight loss due to depression or dementia with depression. And this is mirtazapine. We typically like to use this if our older patients are experiencing depression and they're losing weight. It is that preferred antidepressant whenever they're experiencing those symptoms. But there's not a lot of evidence for treating just weight loss without depression. And the last one is Periactin or cipraheptadine, and this is an antihistamine, and it has been shown to increase appetite but not weight in cancer-related cachexia. And this one is also not recommended by the Beers criteria because there are those adverse drug reactions like cognitive impairment, urinary retention, dry mouth, and again, it is an antihistamine. So now we'll talk about overnutrition. Overnutrition is defined by a BMI of 25 to 29.9, meaning they'll be overweight. Obese is greater than 30. Extreme obesity is greater than 40. And obesity typically occurs in 37% of men and 42% of women who are over 60 years old. But in the general population, we know that higher body weight is associated with an increase in mortality and morbidity, specifically because of certain disease states like cardiovascular disease, diabetes, gallbladder disease, osteoarthritis. They can have certain respiratory disorders, and being overweight or obese can also increase the risk for certain cancers. But for older individuals, there shows no increase in mortality with the BMI between 30 and 34.9. But there is an association with increased disability. So when we talk about increased disability, if you have an individual who has a very high BMI and they're older, and they have osteoarthritis, there might be physical limitations. So although it might not be associated with increased mortality, there is an increase in disability. So for overweight or obese individuals without disability, weight loss may not be warranted, but we do know that weight loss can reduce pain. It can improve physical function and prevent disability. It can reduce blood glucose, blood pressure, and cholesterol, and improve overall quality of life. So those who wish to lose weight, those older individuals who wish to lose weight, it's important that they work with the appropriate healthcare providers to determine an acceptable exercise regimen and a meal plan to prevent complications of weight loss. So it's very important that we do take that into account. So although we're not showing there's an increase in mortality with a certain BMI after a certain amount of age, it can increase the risk for disability. And we do know that having some type of physical limitation or issue will impact the quality of life negatively. So now we'll talk about those nutrient deficiencies. So with vitamin D deficiency, it's classified as less than 20 nanograms per milliliter, and it normally occurs because of reduced sun exposure, the inability to synthesize pre-vitamin D, age-related kidney changes that causes the decrease of hydroxylation of vitamin D and reduced intake or dietary intake of vitamin D. There are some recommended daily allowances. So for individuals who are 70 or less, 600 international units or 15 micrograms per day is recommended. And for those individuals who are over 70, 800 international units or 20 micrograms daily is recommended. Vitamin D deficiency is associated with muscle weakness, functional impairment, depression. It can also increase the risk for falls and fractures. So remember, typically when we talk about vitamin D, we also talk about calcium because vitamin D helps calcium absorption. But if someone is experiencing vitamin D deficiency, if their vitamin D level is less than 12 nanograms per milliliter, they will receive 50,000 international units weekly for 6 to 8 weeks and then 800 international units daily. But if they have a vitamin D deficiency that's not as severe, if their vitamin D level is between 12 to 20 nanograms per milliliter, we would recommend 800 to 1,000 international units daily to treat that deficiency. With our calcium, we know that calcium absorption decreases with age, and it's very important to make sure that we're having adequate calcium because we know that calcium is responsible for bone formation. And if our older individuals have deficiencies in calcium, it can cause osteoporosis. So the recommended daily allowance for men between 51 and 70 years old, it is 1,000 milligrams per day. Men who are over 70 years old and women who are over 50 years old, it is recommended that they have 1,200 milligrams per day, and there is a maximum amount of 1,500 milligrams per day. With our vitamin B12 deficiency, this would be considered a vitamin B12 level less than 200 picograms per milliliter, and it's normally due to poor absorption. And the recommended daily allowance is 10 to 15 micrograms per day. And it does affect 10 to 20% of older adults. And vitamin B12 deficiency can cause cognitive impairment. It can cause neuropathies. It can also cause anemia, which we will talk about in a minute. And the treatment for vitamin B12 deficiency would be 1,000 micrograms daily. And with iron deficiency can lead to anemia, and the recommended daily allowance is going to be 8 milligrams per day. And normally our older individuals are iron deficient, typically due to reduced absorption if they have any gastritis that causes them not to be able to absorb iron, or if they have any genetic issues. But again, we will talk about iron in a little bit more detail when we talk about anemia. But these are just the recommended daily allowances for these vitamins and nutrients. And it is similar to the chart that was in your chapter 11, but it has been updated because the chart in chapter 11 was a little bit out of date. So it did not have the updated recommended daily allowances for these vitamins and nutrients. So your next lecture question evaluation, number 9, is based on Ms. Penny's profile and the supplementation recommendations. Which vitamins and nutrients should she be receiving? Indicate specific dosing, timing, and proper counseling. So now we'll get into talking about going over anemia in the older population. So anemia is defined as a hemoglobin of less than 12 grams per deciliter in women and less than 13 grams per deciliter in men. And it does affect about 10% of women over 65 years and older, and 20% 85 years and older, and 11% of men 65 years and older, and 26% of men 85 years and older. So it's normally caused by iron deficiency, nutrient deficiency, chronic disease, if they have any chronic inflammation or kidney disease, or they could have anemia that's unexplained or not easily determined. And I will go over all the different types. And anemia can negatively impact the quality of life. So when we talk about assessing individuals who might have anemia, it's very important that we do get a history, a thorough history from them, because there are certain chronic medical illnesses that can cause anemia, like chronic kidney disease, cancer, the use of NSAIDs, aspirin, or blood thinners, because these things can cause GI bleed. The same with if they have gastric surgery, if they've had a gastric surgery, this can actually cause a decrease in absorption of iron. Or if they have any intestinal disorders, this can also cause a decrease in iron absorption. If they have a family history of anemia, like thalassemia, which is a genetic disorder characterized by decreased red blood cell and decreased hemoglobin, or if they have hemoglobinopathy, which is also a genetic disorder with abnormalities in the structure of hemoglobin. We'd also want to know if they have any autoimmune disorders like lupus or rheumatoid arthritis, because certain autoimmune disorders can attack the body's own red blood cells, causing hemolytic anemia. If they've been exposed to any toxic chemicals, and of course in advanced age, because in some individuals they can lose the functioning of bone marrow. They'll have an increase in chronic illness, a decrease in nutrition, and chronic alcohol consumption is something else that we also have to take into account. So with assessing anemia, some labs that we need to look at would be a complete blood count, iron profile, vitamin profile, erythropoietin level, and a stool sample for occult blood. So with our CBC, we know that hemoglobin carries oxygen throughout the body. And individuals who have anemia, remember, it's going to be less than 12 grams per deciliter for women, less than 13 grams per deciliter for men. And this is just indicating the typical normal range. And normal ranges may vary by institution or the lab that's analyzing the value. So we'll utilize these lab values for your normal values. Also, dehydration can cause a false increase in hemoglobin. And these that are indicated in red, these are the primary ones that we look at whenever we're going to assess the types of anemias that I'm going to discuss today. So with our red blood cell count, or RBC count, this is the number of red blood cells per liter of whole blood. And it's yellow because we typically wouldn't necessarily look at this unless we suspect an individual has hemolytic anemia. But with the anemias that I'm going to discuss today, red blood cell count might not be something that we would necessarily look at on a lab value. Of course, if it is abnormal, we would do some further investigation. With our mean corpuscular volume, or MCV, this measures the average red blood cell size. And this is a diagnostic parameter for evaluating anemia and differentiating if it's macrocytic, microcytic, or normocytic, which also would help to determine the type of anemia the person is experiencing. So MCV is essentially the average red blood cell size. And then we have red cell distribution with, or RDW, and this measures the variation in the red blood cell size. So when we look at those red blood cells and we're differentiating between microcytic and macrocytic, macrocytic typically would be, so our larger blood cells, it would typically be greater than 100 normally. And that's what would constitute as macrocytic, is greater than 100. And the vitamin B12 and folate deficiency is the primary type of anemia that will cause macrocytic anemia. And remember, with macrocytic anemia, the individuals will typically have a high MCV. With microcytic anemia, the red blood cells are going to be smaller than normal. And microcytic indicates that it's less than 80. So thalassemia can cause an iron deficiency anemia, pyridoxine deficiency, and then certain chronic diseases can also cause microcytic red blood cells. We would also want to look at the iron profile. So the total serum iron would essentially be the serum iron of the blood. And then we also have the total iron binding capacity, or the TIBC. And this measures the ability of iron to bind in the blood to be transported. So this is going to be a very important lab value to pay attention to when we're looking at individuals' labs if we're assessing them for anemia. And then our ferritin stores, ferritin actually stores iron. So it stores the iron and it releases it when it is needed. And the normal range would be 20 to 250 nanograms per milliliter. And then we have our vitamin profile. So these would be the lab values that we would look at to identify vitamin B12 deficiency anemia and folic acid deficiency anemia. So our folate would deficiency would be less than 2 nanograms per milliliter. With our vitamin B12 or cobalamin, deficient would indicate less than 200 picograms per milliliter. And then we have 2 additional labs. These are not vitamins, but typically we'll do these when we suspect someone might have a vitamin deficient anemia. So we have methylmalonic acid, which is B12 is actually needed for methylmalonic acid conversion. And if there is a B12 deficiency, methylmalonic acid will actually be increased in the body. So this is one of those key diagnostic factors for vitamin B12 deficiency. And then we also have homocysteine, which is an amino acid produced from proteins, and there will be increased levels, and this can indicate a B12 or a folate deficiency. And the normal range is 3.3 to 10.4 micromoles per liter. And then we have an erythropoietin level and a stool specimen that would be assessed. And normally the erythropoietin level, it's not ordered frequently. And if it is ordered, it's ordered when there is a high red blood cell count. And the normal range is 4.5 to 21.3. But low levels do occur with chronic kidney disease or myelodysplasia, which is a disorder where there's a destruction of red blood cell production, a disruption in red blood cell production, typically due to issues with the bone marrow. With our stool specimen, we would use this to test for occult blood related to GI bleed, whether it be upper or lower. And if there is blood in the stool, again, it can indicate lots of different things, but primarily we're looking to see if there's an upper GI bleed, they will have black tarry stools. If there is a lower GI bleed, they will have hematochezia, which is that bright red blood. And sometimes blood in the stool can indicate hemorrhoids, which of course is less serious. But if there is any blood in the stool, we do want to make sure that we're doing proper evaluation, because they could have a GI bleed or they could have GI cancer. So when we're looking at a stool sample, it is specifically to identify if there is bleeding, because excessive blood loss can lead to anemia. And we would want to evaluate 3 specimens or 3 bowel movements. And we want patients to stop taking iron supplements 10 days before and avoid red meat and foods with red dye 3 days prior, because this can affect what the stool sample looks like and alter the results. These are those lab values and how they will look for the different types of anemia. So we have vitamin B12 deficiency, folic acid deficiency, iron deficient anemia, and anemia of chronic disease. And you'll see all the different, how they'll actually present. So obviously hemoglobin is going to be less in all of them. Hematocrit is going to be less in all of them. But what we start looking at in terms of the differentiation is the MCV, the MCH, the MCHC, the RBC size. Those will be different. And then of course, depending on what we're looking at. So obviously vitamin B12 and folic acid deficiency, we're not going to be looking at iron, but these would be the iron differences, and I will talk about those in just a minute. So the symptoms of iron deficiency anemia can include fatigue or weakness. It can include pale skin, cold hands and feet. They can have shortness of breath. So remember, our red blood cells are responsible for transporting oxygen throughout, and hemoglobin is what holds on to that oxygen. So if you have an issue with iron, your hemoglobin is not going to be able to bind to oxygen to transport it throughout. So that's one of the reasons why individuals experience all these different types of side effects. They can also have cognitive issues. So that's another reason why if an individual, they are experiencing fatigue, weakness, cognitive issues, that's why we would want to get an iron level, or we would want to look to see if they're experiencing anemia, because all of the symptoms of anemia can present like other disorders. So typically anemia would be a differential diagnosis for a lot of other things. So with iron deficiency anemia, it is a microcytic anemia, meaning the red blood cells will be smaller than normal. And it is caused by excessive blood loss or inadequate dietary intake. Primarily in older adults, it's going to be due to blood loss. So there is some type of bleeding that's going on, and normally it's a GI bleed, which is why we always want to make sure that we're monitoring to make sure they're not taking any medications that could potentiate GI bleed, or if they're taking chronic NSAID use, that they are on a PPI to prevent them from experiencing a GI bleed. Some of the symptoms I've already talked about: weakness, irritability, fatigue, exercise intolerance, tachycardia. So when we look at those specific lab values, iron deficiency has several different stages. So of course, the hemoglobin and hematocrit are going to be decreased. The MCV, remember that mean corpuscular volume, remember that is essentially the size of the red blood cells. So iron deficiency anemia, it's microcytic. So our MCV is typically going to be decreased, meaning it's going to be small because the volume of the red blood cell is small. But what happens is iron deficiency has several stages. So in the early stages, the iron stores can be depleted without anemia, but further iron depletion causes anemia, and the cells are initially normocytic. But as the iron continues to decrease, the red blood cell size continue to decrease. So in the early stages of iron deficiency anemia, the red blood cells are going to be normocytic. But as the iron deficiency continues, it will become microcytic. And microcytic is iron deficiency anemia is a microcytic anemia. And then of course, the iron is going to be decreased. The total iron binding capacity, or the transferrin, is going to be increased. The saturation is going to be decreased, and there will be a decrease in ferritin. So with our iron deficient anemic patients, our goals of therapy would be replacement of that depleted iron stores and correction of the anemia. Of course, we want to exclude or treat other causes. So if there is some occult bleeding or GI bleeding, if they do have that PUD or GERD or anything that could possibly be causing bleeding, we want to make sure that we're treating that. And then in terms of repletion of those iron stores, oral supplementation of 200 milligrams of elemental iron per day, ferrous sulfate, 325, 1 to 3 times per day, 1 hour before food. And that's typically the main one. But I will go over with you guys the other forms of iron. But the adverse drug reactions include constipation, cramping, nausea, and we may give the iron with meals, but food actually will decrease the absorption of the iron. So we can do that, but you would more than likely reduce the absorption, or you can substitute with ferrous gluconate or ferrous fumarate, because this contains less elemental iron, so it'll be less likely to cause any type of constipation, cramping, or nausea. With older patients, they may need to help reduce that constipation issues, perhaps giving the ferrous sulfate 325 once or twice a day is normally recommended, but it can be taken up to 3 times a day, especially if they don't have any issues with the GI side effects. But the bioavailability can increase by administering vitamin C 250 to 500 milligrams with the iron. And the hemoglobin levels may increase by 1 to 2 grams per deciliter per 2 weeks, with symptom improvement within a week and full improvement in iron store repletion in about 4 months. And if needed, parenteral supplementation with iron, so IV iron or red blood cell transfusion, may be necessary in some patients. And these are the 3 different types of iron that we have on the market. We have ferrous sulfate, which provides 195 milligrams per day if 325 milligram tablets are taken 3 times a day. So it will provide a total number of 195 milligrams daily. The ferrous gluconate contains 11% of iron, and it's typically taken 600 milligrams 3 times a day. And the ferrous fumarate is 200 milligrams taken 3 times a day. So these are the versions of the oral iron supplements on the market. We do have to make sure that we are making individuals aware of those drug interactions with iron, because we do know that there are lots of drug interactions. So it can cause, these medications on the left can cause decreased iron absorption. So are antacids, because they affect the acidity of the stomach, and iron is best absorbed in an acidic environment. That's one of the reasons why vitamin C can be given and possibly help with absorption. But anything that decreases the acidity of the stomach will decrease the iron absorption. So our antacids, H2 blockers, and PPIs, we use them for GERD. We utilize them to decrease stomach acid, as well as cholestyramine, which is a cholesterol agent. And then these medications, iron actually decreases the absorption or the serum concentration. So levodopa, which is in Parkinson's disease medications, levothyroxine, our penicillamines, quinolone, and tricyclic tetracycline antibiotics, and bisphosphonates. So remember, with our antibiotics, we want to make sure that we're spacing them from iron by a certain amount of time, because it can chelate and decrease the absorption. The same with our levothyroxine, and then we know our bisphosphonates absorption is decreased if it's taken close to any type of medication. With our vitamin B12 deficiency, individuals can experience some of those similar symptoms of iron deficiency anemia, but there are some added things. So they can experience some fatigue and some memory loss. But with vitamin B12 deficiency, they have a lot of neurological side effects. So numbness and tingling. They can experience some sore tongue or irritability. And with our vitamin B12 deficiency, because it can cause some neurological changes, those are some of the symptoms that are a little bit different than our iron deficient anemia. So with our vitamin B12 and folate deficiency anemia, this type of anemia is macrocytic, meaning the red blood cells will be very large, and it is typically caused by inadequate dietary intake, or malabsorption. So this could be genetic, it could be medication induced. So review the medications in chapter 16 that talks about those medications that can reduce vitamin B12 or folic acid absorption or conversion. And also chronic alcoholism, because if an individual is a chronic alcoholic, they will not be receiving the proper nutrition, and they're more likely to experience B12 and folate deficiency. So specifically with B12, the symptoms, it can take years to manifest. And general anemic symptoms, meaning that they'll have the fatigue, paleness, shortness of breath, but then you have the addition of those neurologic complications like the tingling, paresthesias. They can have ataxia or dementia-like symptoms. And if it's so severe, they could also have psychotic symptoms, and then even the unexplained neuropathies. With folic acid anemia is very rare, but if it occurs, it can occur within weeks. And it's very rare because in the United States, we actually fortify foods with folic acid. And it'll have those general anemic symptoms like fatigue, paleness, shortness of breath. But with this one, individuals can have some numbness or tingling, loss of appetite, or weight loss. So with diagnosing or looking at lab values for vitamin B12 and folate deficiency anemia, you can take a look and see that all these things are the same. Hemoglobin, hematocrits decrease because it is macrocytic, the MCV, the MCH, and the RDW and RBC size are all going to be increased. It is a macrocytic anemia. But depending on which lab value you look at, obviously for vitamin B12 deficiency anemia, vitamin B12 will be decreased. With the MMA, the methylmalonic acid, this one will be increased, but it will remain normal in folic acid deficient anemia. So that's very important because essentially all of the lab values will appear the same, of course, with the exception of the B12 and folate levels, but the difference between the two will be that methylmalonic acid. It will always be elevated in vitamin B12 deficiency, and it will always be normal in folate deficiency. Now, can vitamin B12 and folic acid deficiency anemia occur together? Absolutely, it can. But typically, the folic acid deficiency anemia is it's very rare. So this is an algorithm where if individuals are suspected of having vitamin B12 or folic acid deficiency based on one of the following, so if they have an underlying condition or a diet associated with deficiency, so if they have severe dietary restrictions, like if they're a vegan, if they have macrocytic anemia with low reticulocyte count, if they have pancytopenia, neutrophil issues, or unexplained neuropsychiatric abnormalities, then of course we want to get vitamin B12 and folic acid levels. And again, when assessing patients who are experiencing certain symptoms like cognitive impairment or depression, we always want to get vitamin B12, folate levels, and iron levels because we want to utilize these values to do some differential diagnosis. So we'd measure their B12 and folate levels. If one or both levels are borderline, then we would measure the methylmalonic acid and homocysteine. If the methylmalonic acid is increased and the homocysteine is increased, that means that they have vitamin B12 deficiency. If the methylmalonic acid and homocysteine is increased, that means they have folic acid deficiency. If the MMA is normal and the homocysteine is normal, that means that vitamin B12 and folic acid deficiency can be excluded. And then if one or both of those levels are deficient, then they have vitamin B12 or folic acid deficiency, depending on which level is deficient. So when we look at treatment for B12 deficiency and folic acid deficiency, the goals of therapy will be to replace those nutrients and correct that anemia. For B12 deficiency, oral supplementation, 1,000 micrograms daily for 1 month, and some may actually need lifelong therapy. So it does come in oral formulations. There's also an IM or sub-Q of cyanocobalamin, and it would be 1,000 micrograms once a week for 4 to 6 weeks until the stores are replenished. The hemoglobin and hematocrit are normalized, and then once monthly if lifelong therapy is needed. If there is severe deficiency, then 1,000 micrograms several times a week, several times weekly for 1 to 2 weeks, and then weekly until normalized, and then monthly if lifelong therapy is needed. And that would be for the IM or sub-Q. There is a nasal formulation called Nascobal, which is 500 micrograms, a nasal spray, and efficacy has not been established, but it is something that is on the market. For folic acid deficiency, we of course would want to exclude or eliminate other causes like medications that could be causing it, or alcoholism, or if they have a very strict diet where they don't consume a lot of folic acid. And then of course, supplement with folic acid 1 to 5 milligrams daily until corrected for about 1 to 4 months. And then we have anemia of chronic disease, and causes of this anemia is going to be multifactorial. It includes inflammatory conditions like infection, rheumatologic disorders, medications that suppress the bone marrow production. Individuals who have chronic kidney disease, they can experience anemia of chronic disease due to a reduced erythropoietin production. And this will be characterized by low serum iron, low or normal iron binding capacity, and an elevated or normal serum ferritin. So if you take a look at anemia of chronic disease and iron deficiency anemia, you see they will have some of these similar values. Okay, so depending on how it presents, they could be similar. So the MCH in acute or in anemia of chronic disease might be low or it might be normal. The RBC size is normocytic for anemia of chronic disease, but remember, iron deficiency anemia can be normocytic also in the early stages. But the values that will be different, obviously different, will be the total iron binding capacity and the ferritin level. So these things you will be able to identify and differentiate between anemia of chronic disease and iron deficiency anemia. So how we treat anemia of chronic disease, of course, we want to assess and treat the underlying cause. So if there's occult bleeding, GI bleeding, if the person is taking any medications that are causing bone marrow suppression, then we will want to eliminate that if possible. If they do not have chronic kidney disease, then again, we would assess and treat the underlying cause, and erythropoietic stimulating agents can possibly be utilized, but these are not FDA approved if the individual does not have underlying chronic kidney disease. A blood transfusion can also be done. For those who have anemia of chronic disease and they do have chronic kidney disease, parenteral iron supplementation and erythropoietic stimulating agents can be utilized. ESA therapy is considered when the hemoglobin is less than 10 grams per deciliter, but the hemoglobin should not go above between 11.5 and 13 grams per deciliter, because there is an increased risk for cardiovascular events and thromboembolic events, stroke, mortality with aggressive treatment. So when individuals have anemia of chronic disease due to kidney disease, we want to make sure that the therapy is not so aggressive, because once that hemoglobin gets too high, then there's that increased risk for cardiovascular events. So these are the erythropoietic stimulating agents that are currently FDA approved. We have epoetin alpha, which is Epigen or Procrit, and darbepoetin alpha, which is Aranesp, and both of them are indicated for chronic kidney anemia and chronic kidney disease and cancer, but Epigen and Procrit are only indicated for HIV. They do have similar side effects. The Epigen does have more side effects than the Aranesp, and they both do have a black box warning for that increased risk of cardiovascular issues if they go over the hemoglobin levels of 11 grams per deciliter. Now, this is per the FDA, but then the kidney specialists and the literature, they recommended that not going over that 13 grams per deciliter. And the last type of anemia is going to be the unexplained anemia, where we typically don't have any cause, we can't identify anything. It's also called idiopathic anemia of aging, and it is the most commonly in the very old individuals. So remember, the most common anemia in our geriatric population will be the iron deficiency anemia, and it'll be typically due to or the most common cause for iron deficiency anemia will be due to that bleeding. But with our older population, the unexplained anemia is the most common. And we cannot specifically identify a cause, but we do think that there are those contributing factors like hormone reduction. There is chronic inflammation, even if they don't have chronic inflammatory disorders. There's that reduced kidney function that happens with age. There's also impaired bone marrow function that can happen in our very old individuals. So with treatment, we want to assess and treat any identifiable underlying cause if possible. ESA therapy can be started, but it's not FDA approved, and there is limited data, or a blood transfusion can be done. So your last lecture question evaluations will be, these are Miss Penny's labs, and she did get full labs for anemia. So she did get her labs for iron deficient anemia, folic acid deficient anemia, and B12 deficient anemia. So those are her labs. And based on her labs, what type of anemia does she have? What are your recommendations for therapy? And provide counseling points and monitoring parameters. In summary, older patients should be assessed for GI disorders and treated appropriately. Prevention of constipation should be instituted as this can minimize the risk for impaction and fecal incontinence. In terms of nutrition, undernutrition and weight loss can be caused by GI disorders, dysphagia, difficulty swallowing, certain medical conditions, dietary restrictions, lack of financial resources, and limited ADLs or functional disability. Proper nutrition and supplements should be instituted to prevent frailty and vitamin deficiencies because we do know that a lower body weight has a poorer prognosis than a high body weight. And patients presenting with symptoms of anemia should be assessed for iron deficiency, blood loss due to medication use, GERD, ulcers, if they have any nutrient deficiencies, or if they have chronic kidney disorder. And the role of a pharmacist is, of course, work with the interdisciplinary team to assess geriatric patients and identify those who are at risk for developing some of these issues that are more common in the older population, evaluate medication regimens to identify anything that might worsen GI issues in our older population, recognize when patients are experiencing dysphagia and recommend appropriate evaluation, evaluate medication regimens to determine appropriate changes for those with difficulty swallowing, counsel on proper nutrition and how to prevent constipation and GERD exacerbation, and recommend appropriate use of vitamin supplements when needed, and evaluate laboratory values and recommend therapy for anemia when appropriate. So if you had any questions during this very long lecture, make sure that you write them down so that we can discuss them. Of course, you guys know that you can always email me. Be reminded that your lecture question evaluation number 5 will be due on Blackboard Tuesday evening, which will be the same day as your midterm exam. So please make sure that you plan appropriately for submitting that so you're not stressed out with your exam and submitting your correct and complete lecture question evaluation. And also bring your document in class so that we can discuss your answers. And I will see you guys on Tuesday for your midterm.